Hi, good morning everyone. Very nice to be here in Aurangabad, and I'm really happy to see you all, and hopefully you all are happy to see me as well early morning on a Sunday. So today I would be talking about some of the pathologies of the ankle joint. I would really like to thank Dr. Prasanna for having us here and being so hospitable, and all the residents here helping us out, and of course MUS Society. So just few of the pathologies that I have accumulated, and some of my colleagues, and of course Dr. Nidhi Bhatnagar has really helped us in accumulating some of the cases. So let us have a look. So very nice lecture by Dr. Gaurav. So I'll just build up on a little about how we review the ankle joint. We divide the ankle into 4 compartments. So the most common pathologies are seen in the lateral ankle. So the lateral ankle pathologies, again pathologies would be involving the tendons, the retinaculum and the ligaments. So all the pathologies in ultrasound that we see around the ankle is on the tendons, retinaculum and ligaments. So lateral ankle pathologies would involve peroneus longus and brevis tendon. And the retinaculum would be involved whenever there is any break in the retinaculum, there would be subluxation. Ligament, as explained nicely by Dr. Gaurav, there would be ligament like the talofibular ligament and the calcaneofibular ligament injuries, and the sinus tarsi syndrome. So so the peroneal tendons are the peroneus longus and brevis tendon. They are held together in place by a superior peroneal retinaculum. I hope this is not projecting. This is a pen. Okay. So the peroneal tendons are held together in place by a superior peroneal retinaculum, which attaches at the lateral end of the lateral malleolus and goes posteriorly towards one of its slip. The superior slip goes towards the tendoachilles and the inferior slips goes towards the calcaneum. There is another retinaculum, which is the inferior peroneal retinaculum, but clinically that is not important. The most important retinaculum is the superior peroneal retinaculum, and we will have a look at some of the pathologies regarding that. So for the description purpose, we divide the lateral ankle pathology into zones. So zone A is under the superior peroneal retinaculum, zone B is under the inferior peroneal retinaculum, and zone C is under the cuboid notch. And the pathologies involving the peroneal tendons would be tendinopathy, subluxation, dislocation and splits and tear. So this is an example of tendinosis. What do we see here? I mean, if I run through, can someone tell me what are we seeing in this? So what are we seeing here? That's a peroneus longus tendon, and the peroneus brevis tendon is here. So what is the pathology that we are seeing here? That there is a deformity in the shape of the peroneus brevis. See, when we see the peroneus brevis tendon, there is more of muscle that we see, and then there is a tendon formation. So that's the peroneus brevis tendon, which is more of muscle and then forming into the tendon. And the peroneus longus tendon forms a tendon long before the peroneus brevis. So that's the brevis and that's the longus. The deformity that we see here is the softening and the deformation of the shape of the peroneus brevis. There is little bit of fluid accumulation, and there is then increased vascularity. So that's the tendinopathy. There is another example of the tendinopathy that I will show you. So that's again the brevis tendon, that's the longus tendon. The brevis tendon has assumed this boomerang shape, so its shape has changed. So what are the causes of any tendinopathy? It's a repetitive overuse, so and any sudden trauma. So that would cause a tendinopathy. Also there can be some tears when there is so much of tendinopathy, so much of overuse. I am not sure. I'll read about it and I'll let you know. Give me some time. But the shape is boomerang shape, so that's all that. Yeah. So here in this example, we also see that the shape has changed and there is a longitudinal tear within the peroneus brevis, and there is so much of increased vascularity. Okay, so little bit of fluid is fine in around any of the tendons, but in case of peroneal tendons, if there is any fluid more than 3 mm, we should have some suspicion. Large amount of fluid would be associated with tenosynovitis, but a very small amount of fluid could be a sign of ligament injury, especially the calcaneofibular ligament injury. I think I am going back. Okay, fine. So coming to, so now finished with the tendinopathy, I am coming to subluxation. So there are two types of subluxation. One is intrasheath subluxation, when the retinaculum is intact, but it is only lax, it is not torn. And the other type of subluxation is when the retinaculum covering the tendon sheaths is itself torn. Okay, so there is some trauma involved there. So let us have a look at the example. So this is intrasheath subluxation, where the ligament is just the retinaculum is just lax. So what happens is, with any movement, any dynamic movement of the foot, the relationship between the longus and the brevis would change within the tendon, within the sheath itself, within the compartment itself, and these repetitive injuries will give rise to tear. So tear would be in the brevis tendon, and the longus tendon would insinuate within those brevis tendon. So yes, again a video, I don't know how I'll be able to. So what we see here is, so this is a dynamic evaluation. We see that because of this lax retinaculum, the relative position, so the ligament should not move like that within the retinaculum. We see that the position of the tendon should not move. Now we see with the dynamic motion that the tendons are moving within the retinaculum. Can you see? So this is on a dynamic maneuver. So that's the intrasheath subluxation. Next we go to the we go to the subluxation dislocation. Okay, so next is the subluxation where there is tear of the retinaculum. So what happens with this tears are that there is more movement of the tendons. But ये वाला slide change. Okay, so here this is an asymptomatic side. So what we see here is, that's the lateral malleolus, that's the position of the brevis and longus tendon, and when there is a tear of this ligament, what happens is the tendon can jump over and can go to the other side of the malleolus. So that's a video. I think you will be able to appreciate yourself. What do we see here is, that's one tendon. Can you see how that the other tendon just jumped over to the other side? We will see it again. So here we see that there are two tendons on the same side, and here you see that one of the tendon has gone to the other side of the malleolus. So again this is graded into 4 types depending upon how much of the ligament is injured. So grade 1 is when there is just a stripping of the superior peroneal retinaculum. Grade 2 is when its fibrocartilaginous attachment towards the lateral malleolus is also avulsed. Grade 3 is when there is also some kind of bony avulsion from its lateral malleolus, and grade 4 is when the SPR is also elevated from its calcaneal side. So coming to the tears of the peroneal tendons, so the most common amongst the two is the peroneus brevis tear. Longest tear doesn't happen so very frequently as the brevis tears, and the commonest cause of brevis tear is the subluxations, as we had seen in our previous example, and the pressure effect from peroneus longus, because it's a very tight compartment. So continuous pressure due to overuse activity can cause the tear and the disfigurement of the brevis and then a split tear. So here is an example. What we see here is there should be only 2 tendons behind the lateral malleolus. Here we see that there are 3 components. So those are 2 brevis and 1 longus component in between. Here this is an asymptomatic side. As Dr. Gaurav said, we always compare with the asymptomatic side. Any abnormality we see on ultrasound, we compare it to the asymptomatic side. So that's the lateral malleolus. We see 2 tendons. This is the symptomatic side. What we see is the longus tendon and 2 brevis tendons. So this is a longitudinal split tear of the brevis tendon. This is just to show the dynamic evaluation. So here we see what is happening is there are 2 splits of the brevis tendon, and that's our longest tendon in between the brevis tendon. And whenever we describe, we always divide it into zones because we are describing it for the orthopedicians. We will describe which zone the tear is in. So as I mentioned, the isolated tear of longest tendon is very rare. It usually occurs along with some major trauma, so there will be some other injuries, and even if it tears, the most common site is at the level of the cuboid groove. So here is one of the example. You can just see this dynamic image. So can you see this? That's the longest tendon. It's in the transverse axis, and what we are seeing here is that there is a tear. There is some fluid going inside. There is also some amount of subcutaneous edema and all those. Okay, so ATFL tears, I think anyone who practices ultrasound gets some or the other referral for ATFL tear, and we have all seen ATFL tears. So that is how an intact ATFL would look like. It has an ecogenic fibrillar pattern, okay, and this is an example of a complete full thickness tear of ATFL. These are the two bundles and the fluid in between. Whenever we do see an ATFL tear, we will also like to do a dynamic examination. Dynamic examination for ATFL would be an anterior drawer test where we would pull the foot forward, and here we see that the distance increases with the dynamic examination. This is an example of ATFL tear with avulsion. So this is a bony avulsion from the lateral malleolus. Also any ligament injury when we see, they are also graded depending upon how much the injury is. So grade 1 would be only just the thickening of the ligament, where we see that the ligament is thick, hypoechoic, also sometimes echogenic because there would be some kind of hematoma there. Grade 2 is when there is partial thickness tear. So what happens is in partial thickness tear, even if we do the dynamic evaluation, there would not be a complete separation. There will be some fibers that would be still intact. Grade 3 would be a full thickness tear. There would be some fluid in between the two ends, and dynamic evaluation really helps whenever there is a ligament tear. We would see that the two ends split more far apart. So this is a normal ATFL. Here I would just show you a clip of dynamic evaluation of an ATFL tear. I hope you all can appreciate. So just give it a moment. So what are we seeing here is these are the two ends of ATFL. Can you see that the fluid, the effusion in the joint here, and fluid going in between the ligament? Can you all appreciate this fluid? So this is on the dynamic evaluation that we see that that's a complete full thickness ATFL tear. I'll just run it once again for you all to observe yourselves. So this is the anterior drawer test that we are doing. And can you see it there? The fluid in the joint space is becoming more evident, and the fluid between the ligament is also becoming more clear. Can you see that? That's the fluid. This is just to show how we dynamically evaluate the ATFL. This is one method. The other method is just the anterior, just a simple anterior drawer test. Okay, so the subtalar joint, that is laterally what we see is a joint between the talus and the calcaneum. is also called as sinus tarsi. So, this joint has structures which contribute to the proprioception, so the stability. So, whenever there is any pathology, any synovitis, any infiltration, fibrosis, there is loss of stability and instability of the subtalar joint. And what we see here is a sinus tarsi syndrome. This is a case where there is synovitis, there is fluid within the joint space, and here is another case showing increased vascularity. So, that is the sinus tarsi syndrome. Okay, coming to now the medial compartment. So, we are done with the lateral compartment. Some of the examples of the medial compartment injury is deltoid ligament. So, deltoid ligament, again, it does not really injure in isolation. There will always be some other injuries, either a lateral compartment injury, because it is a very strong ligament. So, as explained so well in the anatomy lecture, I hope you all remember the components of the deltoid ligament. It is not actually possible to differentiate all the fibers, but we just have a fan shaped motion. We keep our probe fixed at the medial malleolus, just sweep through from posterior to anterior, do our dorsiflexion, plantar flexion, and visualize the deltoid ligament. So, here what we see is a nice deltoid ligament. This is the tibio-talar component, and here what we see is that ligament has become hypoechoic, thick, but I still do not see the complete discontinuity. So, this is just mild grade 1 injury of the deltoid ligament. Here I see that some of the fibers are injured, there is some fluid, but there are still some fibers which are intact. So, this is a moderate injury, this is a grade 2 injury of the deltoid ligament. Okay, so here this is an example of complete tear of the deltoid ligament. So, this is a dynamic maneuver. So, it is only during the dynamic maneuver that the complete tear would be visualized well. So, that is our ligament. What we see here is, can you all appreciate here the fluid and the break of the ligament? We will just go in a loop and see that again. Okay, so that is the complete break. So, this is a complete break of the deltoid ligament. I do not think this is running. Okay, yeah, yeah. Okay, here that is a better break which is seen. So, we will just, I think it is self-explanatory, we can see it all, that these are the two ends of the ligament and the fluid in between. So, that is our grade 3 ligamentous injury of the deltoid ligament. Okay, so anyone remembers the medial tendons? Anyone? What are the tendons do you see on the medial side? Yeah, alright, alright. So, very good. I mean, everyone is paying attention, everyone knows their anatomy. So, tibialis posterior is the most frequent medial tendon which is injured. So, this is a case of tibialis posterior dysfunction. What do we see here? That the tendon is thickened. We see subcutaneous edema. We also see there is a lot of vascularity. Tendon thickening more than 7 mm in tibialis posterior is usually tendinosis. So, this is a case of tendinosis. So, in any case of tibialis posterior dysfunction, you also have to look at the spring ligament, because it can cause a spring ligament injury and then flat foot, and also have a look at the flexure retinaculum. So, that is a case of tibialis posterior tendon syndrome. This is a case of injury. So, what we saw here was, we will just have a look at this clip, that is the tibialis posterior. So, as we come down, we see that there is lot of vascularity, there is this fluid around the tendon, and can you see in this tendon what is happening? It is torn. So, there is some intratendinous tear and increased vascularity, and the retinaculum also shows vascularity. So, this is a posterior tibialis posterior syndrome, where the entire compartment is tight with so much of vascularity. Okay, so there is something called as tarsal tunnel syndrome. In this, what happens is the flexure retinaculum, it forms a tight compartment. Any space occupying lesion or anything which causes pressure in that compartment would also cause pressure on the nerve. So the tibialis nerve will get compressed, there will be a lot of pain. So this is an example of a ganglion which is along the flexure hallucis longus tendon. So can you see that? That's the flexure hallucis longus tendon and that's the ganglion. Okay, and then that's the nerve which is getting compressed. So this patient had presented with lot of pain and the cause of the pain was this tarsal tunnel syndrome. This is on the long axis. So what we see here is that's your tendon and that's the ganglion. So in the any space occupying lesion would cause a pressure effect. Okay. So that's the posterior tibial nerve in the tarsal tunnel. So what is happening here is the nerve is thickened. Now we are comparing the asymptomatic side with the symptomatic side. Here we see that on the asymptomatic side the fascicles or the nerve fascicles are nice, smooth, and what is happening on the symptomatic side that it's all thickened, it's lost its nice that pattern, and on the transverse axis what we see is this is this nerve on the asymptomatic side and here the nerve is thickened. So this was a case of lipomatosis where there was fat accumulation within the epineurium, within the nerve fascicles. Okay, so spring ligament, what is spring ligament? Correct, absolutely. So any tibialis posterior dysfunction would also cause, will also affect the spring ligament. So spring ligament injuries would be either thinning, thickening, and it is a stabilizer for the medial arch, medial longitudinal arch. So any injury to the spring ligament would cause, along with the injury to the tibialis posterior, will cause flat foot, will cause loss of that arch, and in long term there will be osteoarthritis. So this is one of the case where the spring ligament is absolutely thin, it's less than 2 mm. Here this is a case where it is thickened, it's more than 5 mm. So just coming to the last part of my talk, so that's the posterior compartment. Posteriorly we have tendoachilles and this is a case of tendinopathy. So this is non-insertional tendinopathy. So this is somewhere a little further up, and this is the asymptomatic side. We see the nice layers, the skin subcutaneous tissue, the tendon which is nice, echogenic, fibrillar. And what is happening on the asymptomatic side, the skin subcutaneous tissue is thickened, the tendon is thickened, and also the fat has become more echogenic. So signs of tendinopathy on ultrasound is tendon thickening more than 9 mm, there will be vascularity. On transverse axis, sorry I don't have an image, but on transverse axis when we see this tendon, knee deformity which is on the calcaneus. So this with the tight shoe and friction of the footwear, there will be tendinopathy. So the Achilles tendon itself becomes thickened. The Kager's fat pad has also become more echogenic, and also there is bursitis. So precalcaneal and retroachilles bursitis. So that's the Hagelin syndrome. So coming to my absolute last slide, that's the tear of the tendoachilles. What we see here is in the longitudinal axis, we see that the ends of the tendoachilles have been retracted, and the most common site for tendoachilles tear is around 5 centimeter above its insertion, because that's the area where it has the least vascularity, and yeah, trauma is one of the major cause of tendoachilles tear. You will usually have a history of trauma. Just a video clip to show. So that's the space occupied by fluid. You can see the retracted end, It's also very important to do a gentle dynamic maneuver just to see the retracted ends and just to see if there is any entrapment of the Keggers fat pad in that area. So yeah, so that's about it. Thank you so much. And I'm very sorry I don't have any anterior ankle pathology cases. So that's it. Thank you.
Thank you, Pooja. Nice cases.
Thank you, sir.
The most important thing is in posterior, this Achilles tendopathy, the normal tendon is flat, and if you have any pathology, then it becomes swollen or
Yes.
becomes this capsule gets elevated.
Absolutely, yes. Yeah.
So any amount of fluid more than 3 mm in any joint recess
Yes.
should be considered as a pathological.
Yes.
But then always you should compare with the other side. If
Yes.
both are
That's
having the same amount of fluid, then it can be a normal thing.
Absolutely. Comparison in ultrasound is how we would come to a conclusion. So comparison is very important. We always have quick comparison with the other side. So.
The most advantage of the ultrasound is you can have it immediately.
Correct.
And you
Correct.
can compare it. Like not like other modalities, it's very difficult to compare the other side. So that is the
and dynamic evaluation is also something which really helps us in, especially in subluxations and in tears. So any tendon tear or any ligament tear, just do a dynamic evaluation, see.
Thank you. Any doubts you can very well ask right now. They will go for the demonstration. Gaurav and Pooja will be demonstrating the anterior, medial and posterior and lateral compartments, how one can be doing the maneuvers to see better the ligaments, tendons, joints, recess and even the neurovascular bundle also. And then we'll go for a lunch break and then demonstration workshop, hands-on workshop will be there.